For us, it's a pleasure and an honor to introduce Dr. Kelly Vogt, that has been a surgeon for quite a while. She joined the Division of General Surgery of the Department of Western University in September of 2014, and she, since then, has had a very distinguished career. She has won multiple awards as the Scientific Surgeon of the Year and Speaker of the Year. She did her fellowship in LA, and it has been an example for many women surgeons that want to pursue a career in trauma surgery.
Thank you very much. Thank you, and it's an honor to be here speaking. I'm looking very forward to the rest of the talks for today, too. So I'm going to talk today about endpoints of resuscitation and trauma, focusing on when do we stop. We'll talk a little bit about why we even look at endpoints, spend the bulk of the time on the proposed endpoints of resuscitation and recognizing I can only go through some of them in my 20 minutes, some recommendations, and just briefly on future directions. Severely injured patients arrive at our institutions in varying degrees and with varying types of shock. And if you accept that shock is really a state of inadequate tissue perfusion and oxygen delivery, then we agree that resuscitation is undertaken ultimately to restore tissue perfusion and oxygen delivery, ideally to the pre-injury state. This can be accomplished in many ways, which are listed here, hopefully not too much crystalloid, as we've already talked about today. Again, but a bit beyond the scope of this discussion, but I include them here to say that really no matter what the resuscitation strategy we use, the goal is ultimately the same. It's all about restoring oxygen. But the purpose of this talk is not really to talk about how to resuscitate our patients, but in fact, when should we stop resuscitating our patients? It seems pretty simple. Ultimately, we want to stop when the patient is resuscitated. We know that despite all of our good intentions and the effects that we use with our resuscitation in terms of saving the patient's lives, what we do often leads to harm. We've talked about it already this morning, and there are many other examples of the harm that we can cause. So ultimately, we're trying to find a balance between resuscitating the patient effectively, but stopping before we've gotten to the point of leading to harm. And where that tipping point is really what we're going to talk about. And I'll give away the end right now. There is no magic bullet. I'm not going to give you one single endpoint that allows us to know that our patients have been resuscitated. That being said, many people have looked at this for many years, and in 2004, actually quite some time ago now, this group put out clinical practice guidelines in the Journal of Trauma, and essentially what they said is that resuscitation is complete when the oxygen debt has been repaid, tissue acidosis eliminated, and normal anaerobic metabolism restored in all tissue beds, which is a lovely statement, and it certainly is exactly what we're trying to do. The issue with this is that, of course, that doesn't tell us how we know that we've achieved that particular endpoint. So what we're going to talk about in the next about 15 minutes are some examples of endpoints of resuscitation, ones that have been proposed. There are a few more, but this generally sums up what's out there in the literature, and we're going to go through each of these individually. So we'll start with traditional vital signs, and likely the first endpoint of resuscitation we all learned about was vital signs, as is taught in the ATLS course put out by the American College of Surgeons. Traditional vital signs, heart rate, blood pressure, have important roles in certain institutions. However, as endpoints of resuscitation, they are relatively unreliable. Not only are there mitigating factors such as patient's comorbidity, varying pre-injury baselines, and mechanical ventilation, vital signs, more importantly, often normalize long before the hypoperfusion and tissue acidosis have in fact resolved. Some studies suggest that up to 85% of severely injured patients will still have ongoing metabolic acidosis even with normal vital signs. So standard hemodynamics really are insufficient to quantify either the degree of physiologic derangement or the complete response to resuscitation. I should say, however, that they do potentially play a role. What they can tell us is, in many cases, that a patient is transitioned from uncompensated shock to compensated shock. So potentially that they're on their way to reaching the endpoints of resuscitation, though important to recognize that this doesn't mean that they have met them. Historically, there was discussion of physical examination, and this typically related to skin color and temperature. This is not, however, as we know, in the case of our multiply injured trauma patients, a reliable measure, and really the physical exam should be better left for identifying the causes of shock than for identifying that we have in fact adequately managed the shock. So we're going to talk now about metabolic parameters, and I'm going to come back to oxygen extraction ratio in a second, so I'll just skip over this slide. Probably one of the most written about values in terms of endpoints of resuscitation is in fact lactate, which we know is a direct product of anaerobic metabolism. And we know that in our trauma patients, lactate, elevated serum lactate at presentation of greater than 3.4 millimoles per liter, or the inability to clear lactate as evidenced by normalization of these values within the first 24 hours, portends a particularly poor prognosis in our trauma patients. Therefore, many physicians will use normalization of lactate as an important decision point in the goal or in the timing of shifting from their active resuscitation to more of a maintenance phase of resuscitation. However, while lactate is an attractive metabolic marker, it can be readily accessed by the blood. Most labs can turn it around quickly, and it's a nice number that you can follow. We do need to be careful that lactate is probably not, as I said before, the single bullet. Elevated lactate doesn't always equal anaerobic metabolism. In patients with liver or kidney disease, other metabolic derangements, this is certainly, you can have elevated lactic acid levels and they are not in fact in anaerobic metabolism. Similarly, the opposite can be true. Elevated lactate is not the case, is not always measured in the blood in every case where there is anaerobic metabolism. The classic one would be in the case of venous occlusion and failure to elevate the lactate levels. So it's not perfect. People have looked more frequently at base deficit. So base deficit as the amount of base needed to return the plasma pH back to neutral in 1 liter of blood. And it is probably, if lactate's the most common, base deficit is probably the second most common studied in resuscitation of our trauma patients. And really it reflects impaired oxygen utilization. And similar to elevated lactate, elevated base deficit with at greater than 6 millimoles per liter, or failure to correct the base deficit within 24 hours, again, portends a poor prognosis in our trauma patients. And in fact, many have suggested that it's probably more important than lactate. There is certainly evidence in the literature that independent of, for patients with a normal lactate, the base deficit failure to clear it is still associated with a poor prognosis. That being said, just like lactate, there are limitations to the use of base deficit. So high volume resuscitation, though we try to get away from it, particularly with crystalloids and normal saline, leads to a hyperchloremic state and can compound the evaluation of base deficit. Intoxication, particularly with alcohol or cocaine, diabetic state, all make base deficit somewhat difficult to interpret. And pH, while it often comes up with base deficit, really the normal compensatory mechanisms make pH yet another difficult value to interpret it in the setting of our evaluation of these patients. There's a lot of research going on into potential new markers. A small randomized controlled trial among 17 trauma patients looked at these 3 stress-related proteins and identified all of them actually perform better than standard markers. That being said, they take a long time to process, they are quite expensive, and currently are limited in availability for our patients. I say that, I think that there probably is going to be some value, and pay attention to the literature because I think stay tuned as to what's coming in the future with respect to metabolic markers. I said I would come back to measures of oxygen uptake, and we're going to talk about both global and regional measures of oxygen uptake. Venous oxygen saturation is certainly an important potential evaluator. So how much oxygen is being delivered to the tissues versus how much is being taken up by the tissues. And normal oxygen extraction is somewhere between 20 and 30%, and the oxygen extraction ratio of greater than 50% would suggest that, in fact, there's less oxygen being delivered, so the amount that's being extracted leads to a higher ratio. Oxygen uptake theoretically makes a lot of sense, and it's a great idea. Are we delivering enough? Is there more being taken away? However, the practicalities of this, in that it needing to occur in stable patients, really lend itself more to evaluation of our patients in the ICU as opposed to in the resuscitation bay. And really where I see a role for this is in the evaluation of an impact of an intervention. Regional oxygen uptake, as opposed to global oxygen uptake, looking at the microcirculation of the regional tissues. And there's been a lot written about this, and there was significant interest in past years, which seems to a bit have gone by the wayside. There have been multiple techniques proposed in the literature: evaluation of gastric oxygen uptake, sublingual, transcutaneous, near-infrared spectroscopy. However, none of these are currently in widespread use, and I think that is in large part due to the somewhat finicky nature of some of these tests and also the cost associated. So back to hemodynamic monitoring. Similar to our vital signs, static values of hemodynamics, such as central venous pressure, pulmonary artery pressures, which were routinely measured historically, really suffer from the same difficulties. They're a snapshot in time and don't provide us with a ton of information with respect to how the patient is responding. So they really are of limited utility as endpoints of resuscitation. However, with recent shifts towards less invasive pulse contour analysis, I think hemodynamics are making a bit of a resurgence in terms of our evaluation of our patients. Pulse pressure variation, or change in pulse pressure width during the course of a respiratory cycle, provides us with one option and can be evaluated on any arterial waveform monitoring device that you have in your patients, and any mode of mechanical ventilation that the patient is stable on. So in patients with normal sinus rhythm on a controlled mode of mechanical ventilation with a tidal volume of 8, so that's a lot of things that have to be perfect for this to work. But in those circumstances, pulse pressure variation of greater than 12% is associated with volume responsiveness, so the most common types of shock that we have: hypovolemic, also LV dysfunction, obstructive shock, or raised intracavitary pressures for some reason. So it's a nice tool to be able to monitor on a continuous basis to evaluate the volume responsiveness of your patient. Similarly, stroke volume variation, different than pulse pressure variation in that it reflects the percentage change in stroke volume area over the respiratory cycle. And unlike pulse pressure variation, it does require proprietary software to be able to evaluate it, so you need to have the machines in your hospital to be able to do that. That being said, the analysis is fairly similar to that of pulse wave analysis in that it relies on stable mechanics to be meaningfully interpreted. However, when you have a patient on stable ventilatory strategies, again, a stroke volume variation of greater than 12% indicates that your patient is volume responsive. And the volume responsive patient will then respond to preload changes in the setting of this ventilation. Similar limitations for both patients with lung injury, ARDS, high PEEP, non-sinus rhythm, and those on high-dose vasopressors limit our interpretability of these analyses, and so again, make it somewhat difficult. But in summary, I would say that pulse contour analysis provides a far less invasive method for us to evaluate the patients and their response in more of a real-time way than some of the other hemodynamic strategies that we've used in the past. And probably, at least for me, provide an opportunity to intervene and help me make my decision in shifting from the active resuscitation phase to a more stable management. Moving on now to imaging. Bedside ultrasounds really are a mainstay in the trauma resuscitation bay of most of our institutions these days, and because of that, they certainly do play, in my mind, a very important role in evaluating our resuscitation strategies. In addition to the standard evaluation for pericardial fluid and tamponade, focused evaluation for ventricular function, ventricular size, cardiac output, volume status, and fluid responsiveness can give us a fair amount of information as to how we're doing with our resuscitation. Volume status can be measured in many ways: IVC diameter, IVC collapsibility, SVC dispensability. However, whatever method you use, and I would advocate a combination of them, the easy accessibility of the ultrasound makes it an attractive way to evaluate our patients. I will say, however, that with bedside ultrasound, we need to always be conscious of the fact that it is a provider-dependent modality, meaning that you need someone who knows what they're doing and to be able to interpret the results that they're getting to make this a valuable tool. That being said, for patients who are in normal sinus rhythm and relatively stable, and you can get good pictures and interpret them, it certainly can help you identify the hypovolemic patient with things like hyperkinetic ventricular activity, increased LV ejection fraction, dynamic LV obstruction, or a small IVC diameter with respiratory variation. And when you see those things, it certainly makes you choose to act in a way that would improve the volume status of your patient. And the nice thing about the ultrasound is you can watch in real time the effects of your, for example, ongoing resuscitation strategy. I'm going to skip that slide. And is this practical in our patients? This 2013 paper presented at the AAST was a randomized control trial where they randomized 240 patients to either receive limited transthoracic echo or not as part of their resuscitation, and demonstrated that first they could do it, and second of all, that it did actually make a difference. Patients who received the echo did end up in the OR faster. They suggested there might potentially be a mortality benefit as well. But it can be done, and it does make a difference. I put this up because for a long time we thought, okay, we can measure the IVC diameter on ultrasound, so let's do it on the CT scan as well. And there was interest in, since we CT so many of our trauma patients, will this help us in guiding our resuscitation? The short answer from the group at UCSF in this retrospective study is no. In fact, there's really no correlation. So that hypothesis seems to have gone by the wayside. We're going to touch briefly on coagulopathy, recognizing that there are other talks in this session that are meant to go into the details of this, but I do want to talk about it as we heard this morning. Our trauma patients present coagulopathic, and those who present coagulopathic tend to do worse than those who don't. And traditionally this was evaluated with INR PTT. Now we're looking at point of care testing, TAG, and ROTEM. And coagulopathy in and of itself as an endpoint of resuscitation has significant value for patients who are presenting with hemorrhagic shock, which is the vast majority of our patients. Again, this is not a TAG talk, but what's nice about TAG and other strategies is that it provides us an opportunity for individualized resuscitation. It allows us to see in real time what's happening and how to change it and how to improve our patients. And with Dr. Holcomb here with us, I would argue that balanced transfusion as an endpoint of resuscitation, I think, has significant value, although maybe now we're going to be getting into how many units of whole blood. I'm not sure. I'd like your thoughts on that after this talk. It may be a significant, maybe an important endpoint of resuscitation. How well are we doing? Are we actually getting the 1-to-1-to-1 ratio that we espoused to get? So that's a lot of potential endpoints. What does it look like for me? What I say is this. The aim in our trauma patients who present with significant shock is early directed resuscitation aimed at reversing not only physiologic derangement, but also the coagulopathy we see in our trauma patients. There are many potential endpoints that can be used to help guide effective resuscitation, and so your decision as to which to use really needs to take into consideration multiple factors. Not every patient is the same, and as we've talked about, some of these tests require patients who are much more stable than what we see in our resuscitation bay. We need to look at the injury. What's our goal? If we're really treating hemorrhagic shock, then I think some of the coagulopathy and or product ratio and or whole blood transfusion really is the important endpoint that we're trying to make. You also need to look at the provider. We talked about the ability to perform ultrasound or who's around you when that's happening. And if you have that tool, then use it. But if you don't, then you need to come up with another strategy that you're comfortable with to be able to determine when it's time to switch from that active resuscitation phase. And to some extent, resuscitation strategies. A lot of what we talked about today was related to volume status. It's very helpful in hemorrhagic shock, probably less so in neurogenic shock. And where do we go from here? Well, we're still searching for the ideal endpoint. Needs to be reliable, needs to be easy to use, ideally non-invasive, safe, and cheap. Kind of like searching for a pot of gold at the end of the rainbow, but I would like to be the person that finds that. So in conclusion, resuscitation after cessation of shock state but before harm is of paramount importance. And ultimately, it relies on multiple tools to decide when you've reached that point. Future work is required to define more ideal endpoints of resuscitation. And that's it for me. Thank you.